Greetings. Let us talk about endoscopic solutions for colonic perforations and fistulae. So, what is the risk of perforation when you perform a screening colonoscopy versus a diagnostic colonoscopy and when you add therapy? Overall, the risk of screening colonoscopy is pretty low, about 1 to 2 in 10,000 procedures. When you add intervention, the risk increases significantly to about 1 in 1,000 colonoscopies. So you have to be careful when you do any intervention and be able to manage that perforation with endoscopy. Let's talk about who is at risk for perforation. Older patients, patients who have several comorbid conditions, especially cardiovascular or cardiopulmonary diseases, patients who have a limited functional reserve, and patients who have cancer are at a higher risk for complication. When you perform a polypectomy, the risk increases. The risk is also higher in the younger endoscopists with limited experience compared to senior endoscopists with a lot of experience. And this is important because once a perforation happens, the mortality is pretty high. 3 out of every 100 events leads to death. So when it comes to an older patient who has a polyp, it is important to find a senior endoscopist with a lot of experience on his belt to perform those procedures so that these patients can come out without a significant adverse event. Let us talk about the different mechanisms of perforation and how to prevent them. It is important as you go through the colonoscopy to keep in mind the patient's story and also reflect on your scope journey and constantly measure the amount of force you're using to push your scope. If you keep on pushing, there is a possibility for a hockey stick injury, as you can see in this picture, and you could avoid that by using simple measures like water immersion technique or putting the patient position from left lateral to prone or supine. When I was training, we used to use different overtubes, and sometimes I've used a single balloon or double balloon scope. But with the advent of thinner instruments, this becomes a little bit easier. Another mechanism is a barotrauma, where you put in a lot of air and you don't realize you blow up the cecum. This is not much of a problem nowadays with the routine use of carbon dioxide, especially when you're going through a very difficult sigmoid colon that is fixed from adhesions related to pelvic surgery or radiation, and if it is fixed from severe diverticulosis. In those cases, you have to make sure that you use CO2 and use it very little. And if in case you are struggling, try to use water immersion and try to use periodic venting so as to decompress the colon. Venting, I mean not just suctioning, but taking the biopsy valve out. Pull the, pull the biopsy port plug out and let the colon vent out through the channel. I use this quite often in my practice. Another problem related to perforation is a retroflexion injury, especially in patients with small rectum. And in those cases, it is better to avoid retroflexion And you could examine the distal rectum by deflating the rectum and with the use of a cap-fitted endoscope. Next, let's talk about thermal injury. Unlike mechanical injury, where the perforation is obvious at the time of the procedure and it becomes an emergency, thermal injuries may or may not be recognized, and it could lead to a delayed sequence of events, and it is much more dangerous because there is going to be a lot more peritoneal contamination, and these patients may need a diversion procedure. It can happen with polypectomy, EMR, ESD, and when you use APC in the right side of the colon, especially ablating angioectasias. So let's talk about how to prevent perforation related to the use of a heart snare polypectomy. We all know about the principles of current density and how you could use that when you're managing large polyps. When you manage a large polyp, make sure the polyp head is in contact with a larger surface area so that the current traverses through the snare. But on the other hand, if you're not careful about that and the small area is in contact, the current goes through that area and you could end up with a counter burn and perforation. How about principles of managing or preventing perforation when you're dealing with flat lesions? It is important to keep in mind that of all the four layers of the colon, submucosa is the strongest layer. If you preserve the strongest layer in the colon wall, you can be assured that your patient is not likely to have perforation or including delayed perforation. So how do we do that? So when you're doing a polypectomy by injecting submucosal saline and lifting, you have less thermal injury to the muscle. And keeping the snare parallel to the wall, you avoid muscle entrapment. And when you're in doubt, release the snare so as to let the muscle fall back and avoid that muscle entrapment and injury. Once you resect, you examine the resection base for depth of injury. If you see blue submucosa, if you have used indigo carmine or methylene blue to inject, if you see blue submucosa as a mesh, that indicates that your depth of resection is limited to the superficial submucosa. Sometimes you could go a little bit deeper and see the muscles with no damage to the muscles. Whenever there is no muscle damage, those patients are unlikely to develop delayed perforation. Once you have muscle injury, either superficial or deep, these patients are likely to have perforation, and these patients' defects should be closed with clips. And obviously, if there's a perforation, you have to be prepared to close that defect. So let's talk about perforation management. If you notice a perforation while you're doing the procedure in the endoscopy room, if the colon is clean and there's no spillage of content and it's a small perforation, you could close that with various modalities. Clips are probably the best because it can be rapidly deployed. On the other hand, if you have a dirty colon with spillage of contents into the peritoneal cavity, especially with the large perforations related to mechanical injury, these patients should probably go to surgery. So when it comes to closure devices, we have three types of closure devices: through the scope clips, over the scope clips, and over the scope suturing device. And let's talk about each one of these. Over the scope suturing device can be used to close larger perforations, but there's a lot of learning, and you have to take the scope out to load it onto either a therapeutic or a single channel scope. So during that process, there is a risk of peritoneal contamination. The literature on closure with over-the-scope device or suturing device is limited. You could also try and use over-the-scope clip for medium-sized perforations. Again, because you have to take the scope out to load it, there's a risk of peritoneal contamination. Although the technique is similar to band ligation, you should avoid suction. Instead, pull the edges into the cap to deploy the clip. By avoiding suction, you avoid the risk of bowel obstruction and ureteral obstruction from entrapment into the clip. Again, the literature is encouraging, but again, quite limited. Through the scope clips can be used to close perforations. They can be applied immediately, and the learning is relatively easy, but you have to be careful because if you don't apply it, there could be a failure of closure. We have a larger experience with these devices with a good success. I would like to share with you a couple of tips when you're closing with clips. Every clip that is available in the market tends to retract as you close the defect. And if you do not compensate for that retraction, you end up applying the clip superficially. That superficial clip application is not going to last long, and they are going to fall off, and the perforation is likely to reopen. Instead, you should compensate for the clip retraction by either gently pushing the clip or gently pushing the scope so as to get a deep approximation of both edges of the perforation. And the goal is to create a deep clip closure and then document that with photos. And the closure should be mucosa to mucosa, and you take photographs to document on both sides of the clip closure. And when you have a superficial clip closure, make sure you apply 2 more clips on either side so that to get a deep approximation. The limitations of a clip closure are clip detachment with reopening of the wound, and when the patient goes to surgery, the surgeon may have a tough time closing that wound, and clip close defects that failed may require a diversion procedure. If a perforation was recognized during the recovery phase or if the patient has gone home, if the patient is relatively asymptomatic, you could continue conservative treatment. If the patient is symptomatic, then they require surgery. Whether it is a repair or resection depends on the size of the perforation and associated diseases like severe diverticulosis or underlying cancer, in which case the patient may require a resection rather than simple repair. A few words about fistula management. Recently, there is a lot of interest in vacuum therapy. Although the literature is limited, you go in, suction out by applying a sponge into that fistula, and you may have to do multiple times to clear it up. Let's talk about some learning. Let me conclude this by saying that patients who are older are at a higher risk for perforation. Colonoscopy with intervention is at higher risk for perforation. And in order to prevent mechanical injury and perforation, you should reflect on the patient's history and also feel how your scope is feeling as you're going into the colon. Once you do a resection, make sure you examine the base to identify the depth of the resection. If it is a deep involving muscle injury, close the defect with clips. And whenever you have a perforation, even if you've managed it, make sure you get your surgical colleague on board. Thank you.